Vitamin B1, also called thiamine, is a water-soluble vitamin that our body cannot produce. It must come from the diet. Thiamine plays a crucial role in our organism because we use thiamine as a cofactor for several enzymes which are critical to energy metabolism. So, to understand the pathogenesis of thiamine deficiency, we have to recall the biological role of thiamine and reactions where thiamine participates. Thiamine pyrophosphate serves as a cofactor for pyruvate dehydrogenase complex, and pyruvate dehydrogenase complex provides conversion of pyruvate to acetyl-CoA, which then goes to the Krebs cycle with energy production. So, the first function of thiamine is to link glycolysis to the Krebs cycle. The second enzyme which uses thiamine as a cofactor is alpha-ketoglutarate dehydrogenase. Alpha-ketoglutarate dehydrogenase is the enzyme of the Krebs cycle which converts alpha-ketoglutarate to succinyl-CoA, which then goes further through the Krebs cycle with subsequent energy production. The third enzyme which uses thiamine is a branch-chain ketoacid dehydrogenase. Branch-chain ketoacid dehydrogenase breaks down branch-chain amino acids like leucine, isoleucine, and valine to energy intermediates as acetyl-CoA, acetoacetate, and succinyl-CoA. All of them we can degrade in the Krebs cycle with subsequent energy production. And the last enzyme that uses thiamine as a cofactor is transketolase. Transketolase is the enzyme from hexose monophosphate shunt, and recall that one of the functions of hexose monophosphate shunt is production of NADPH, and in turn we use NADPH in fatty acid and cholesterol synthesis, which are essential processes for myelin synthesis and overall for cellular membrane synthesis. And also we use NADPH for reduction of glutathione, which is one of the strongest antioxidants in our organism. The first consequence of thiamine deficiency is cellular ATP depletion, which affects highly aerobic tissues like brain and heart tissue. So, why energy deficiency develops? With deficiency of thiamine, pyruvate dehydrogenase complex cannot work. As a result, the production of acetyl-CoA decreases, which eventually leads to decrease in ATP production. At the same time, pyruvate accumulates, and with accumulation, some amount of pyruvate undergo conversion to lactate, which results in lactate acidosis. With thiamine deficiency, the alpha-ketoglutarate dehydrogenase complex cannot work. This causes decrease in activity of the Krebs cycle, which also leads to energy deficiency. Also, with thiamine deficiency, the activity of branch-chain ketoacid dehydrogenase complex decreases. First of all, this causes buildup of branch-chain amino acids, which on its own can cause systemic toxicity and organ dysfunction. Also, this causes decrease in production of energy intermediates, and without them, the activity of the Krebs cycle decreases, and as a result, the ATP production decreases. And the last enzyme which becomes affected by thiamine deficiency is transketolase. With decrease in transketolase function, the production of NADPH decreases, which first of all leads to decrease in fatty acid and cholesterol synthesis, so it will affect myelin synthesis and cellular membrane synthesis. And also, with deficiency of NADPH, we cannot reactivate glutathione, which results in decrease in antioxidant defense. So, thiamine deficiency causes three major aspects. It's energy deficiency, impaired antioxidant defense, and decrease in myelin synthesis. Exactly these three effects are the cornerstone of all clinical symptoms caused by thiamine deficiency. The first disorder caused by thiamine deficiency, called Wet Beriberi. The pathogenesis of Wet Beriberi is based on energy deficiency that causes decrease in heart contractility. With decrease in heart contractility, the stroke volume decreases, and we know that stroke volume with heart rate gives us cardiac output. So, because stroke volume decreases, cardiac output will decrease. Cardiac output, together with systemic vascular resistance, give us blood pressure. So, because cardiac output decreases, blood pressure will decrease. And decrease in blood pressure leads to decrease in tissue perfusion. Additional factor which is involved in pathogenesis of Wet Beriberi is that energy deficiency also leads to increase in release of nitric oxide from endothelial cells. This causes vasodilation, and the more dilated the blood vessels, the lower the systemic vascular resistance. As a result, more blood volume will stay in the dilated veins. So, decrease in systemic vascular resistance is the additional factor which lowers blood pressure. To keep blood pressure stable, organism has to increase cardiac output. We cannot increase cardiac output by stroke volume, because we do not have enough ATP molecules, but we can increase heart rate. So, one of the symptoms will be tachycardia. But high heart rate is not sufficient to maintain stable cardiac output for a prolonged period of time. Eventually, blood pressure will gradually decrease, and with decrease in blood pressure, tissue perfusion will decrease. And the most sensitive tissue to decrease in blood perfusion is kidneys. In response to decrease in blood perfusion, kidneys begin to produce more renin. Increase in renin production stimulates the entire renin-angiotensin-aldosterone system, which results in increase in sodium and water reabsorption. So, the logic here is that organism thinks that by increasing the blood volume, we can maintain the perfusion of the tissues. But because heart contractility is low, this excess fluid retention will just cause edema, which is the signature feature of the Wet Beriberi. And this state, which is characterized by increased heart rate, systemic vasodilation, and excessive fluid retention, we call high output cardiac failure, and it's a signature feature of the Wet Beriberi. The second disorder, which can be caused by thiamine deficiency, called Dry Beriberi. In Dry Beriberi, the root of the problem is also energy deficiency. Decrease in ATP production leads to decrease in muscle growth and decrease in muscle contractility. This together leads to symmetric muscle wasting. In addition to this, energy deficiency also affects neural cells, where energy deficiency causes decrease in axonal transport, decrease in myelin production, and decrease in activity of pumps, which normally maintain iron gradients. In peripheral neurons, with time, it leads to polyneuropathy, and polyneuropathy, together with symmetric muscle wasting, are two signature features of Dry Beriberi. In the central neural system, energy deficiency leads to both acute and chronic damage. Acute damage leads to Wernicke encephalopathy, while chronic damage leads to Korsakoff syndrome. Together, they cause so-called Wernicke-Korsakoff syndrome. So, in addition to the Dry Beriberi and Wet Beriberi, thiamine deficiency can also cause Wernicke encephalopathy, which is acute reversible state characterized by a triad of confusion, ophthalmoplegia or nystagmus, and ataxia. Korsakoff syndrome, on the other hand, is amnestic disorder which is caused by chronic alcohol use, and presents with confabulation, personality changes, and memory loss. And the pathogenesis and detailed explanation of the Wernicke-Korsakoff syndrome you can find in the separate video on this channel. So, as we see, thiamine deficiency manifests in distinct disorders. The logical question will be why deficiency of the same vitamin causes three different pathological conditions? Well, it depends on several factors. First of all, it's a tissue-specific vulnerability and the presence of comorbidities. The nervous system and heart both have high energy demands, but it all depends between individuals. In some people, neurons are more predisposed to injury, for example, because they are already damaged due to the vitamin B12 deficiency. So in this case, patient will have dry beriberi. At the same time, some people already have cardiac issues, as post-viral myocarditis. This makes them more predisposed to cardiac injury, and because of this, they will have wet beriberi. The second factor is the severity and duration of deficiency. A severe acute deficiency might quickly overwhelm the heart, triggering wet beriberi. In contrast to this, a chronic moderate deficiency may gradually damage nerves, resulting in dry beriberi. Genetic factors also play an important role, because the activity of thiamine transporters or enzyme function differ from person to person, and they determine which tissues will suffer more from the deficiency. In the treatment of thiamine deficiency, we should know that we give thiamine before we infuse glucose. It's important because if we will infuse glucose before thiamine, this will just amplify the damage. It's the most commonly tested concept about Wernicke-Korsakoff syndrome on examinations. And to know why, you have to watch video about Wernicke-Korsakoff syndrome.